here. I'm going to go ahead and turn the floor over. They have an exciting talk for you today about return to use and navigating that. So without any further ado, I'll let y'all take it away.
I'm going to share my screen if that's okay with you, Meredith, because I made one more little tweak to it like an hour ago.
Yeah, cool.
Okay, I think you all are seeing a slide that says normalizing the recovery process. Yes? Yes. Okay, good deal. Because that is what we're doing, is trying to talk about normalizing the recovery process, and kind of what that looks like. Disclosures, none. I'm not making any money anyplace else, nor is Meredith. Way. Basically, today we're going to cover looking at things like return to use. You can know some verbiage, word usage may be a little bit different than what we hear sometimes. Just trying to use language that is encouraging, not discouraging, not stigmatizing, not biased. So return to use, recovery drift, and then some key medical and behavioral interventions. So we're going to kind of hit on all of these things, and hopefully I won't drone on too far into the weeds, but that is something of my MO. So I'm going to watch myself. And luckily we've got Meredith to kind of keep me on track because I got to stop and hand it over to her. Just to kind of think about it, what we do, the work we do, how is it different than the work anybody else does? And other chronic medical or mental health conditions, do we require perfection in treatment adherence? So actually, I had a conversation last night, working on, believe it or not, the test for addictionologists, kind of coming up with the framework for it. And one of the things that came up was the term non-adherence. And I don't know, it was late. I hadn't eaten dinner. All of a sudden, somebody showed me a soapbox and I stood on it. I really do not like the term non-adherence. I feel as though that really is kind of a blaming term, and it's just sort of flipping the, like, somebody's doing something on purpose to not do what we told them to do. And it's like not really what's happening. It's not reality. And so I don't think it's reality in any of the work that we do, that our patients are sitting there going like, I'm going to not do this just to make my provider angry because I have that power and I want to wield it. There are things going on with the individuals that we work with that make it difficult to follow through with treatment plans, especially if it's a treatment plan that, we've come up with predominantly. How much have they gotten to participate in it? Is it realistic? These are important things to think about. And also, the time that I was in a Chinese restaurant having a lovely plate of fried rice, and I looked up and saw my very not well controlled diabetic with an even larger mountain of fried rice on his plate. You know what? That probably was not in keeping with his diabetic diet. All right, it's okay. He was literally hiding behind his mountain of rice. So it's okay. Rice is good. So any other situations in which we require perfection and treatment adherence, and then just that term relapse. So I used return to use earlier. Relapse, remit, relapse. I mean, we do kind of hear that, but I think it's a term that we're getting away from in other medical conditions and behavioral health conditions, mental health diagnoses. It's one that we can do away with in this field as well. Because it just makes it rhymes with collapse, right? Like everything just fell apart and everything you did is gone now. It's worthless. And I sometimes will hear patients refer to it as that way. It's like, well, I relapse, like I'm back at square one. And it's like, no, actually you're not. Because when you were at square one, you were not in my office talking to me about it. So return to use is the way in which people get to use the words that they want to use. Word choice is a choice. It's yours, your language, how you want to wield this thing that our tongue and lips do, and our vocal cords, how you want to express yourself, but knowing that the words that we use do have meaning and being mindful of the way in which we use them. I don't see the numbers of the slides, but I feel like this is where you
I
get to
feel like
kick
this
off
is
now.
me.
Okay, excellent. Because I have nothing to say about this slide, so I'm
Okay.
going to
Joyce didn't see it till last night. No. All right. So I am trying to introduce the idea of, so part of the reason why there's this kind of this continuum of use, this continuing of return to use that maybe happens over the course of recovery is to kind of set up that idea is also, I think it's helpful when I teach this to my students, is to set up this idea that like people don't just like end up with a use disorder overnight. It's this trajectory into this process that can take decades for many individuals. So usually what happens first is someone tries a drug or medication. It could be and often the trajectory is they're most likely to start off trying alcohol first. A little bit older, it will be when people would try cannabis or marijuana. And then we see that early transition age youth, that 18 to 22, is where the first incidence of use of some of the drugs that we are more likely to be treating in some of our clinics, but heroin, cocaine, methamphetamine will happen. For the majority of the population, there's just going to be an incidence of use. They use a few times. They never ever will go further than just like trying. We never really hear about this that much if we're on the addiction medicine side of things. Maybe if you work outpatient, short mental health clinics, you hear a little bit about the incident of use, but usually we're talking about people who have much more than just incident. The trajectory from when people transition from first instance of use to regular use is usually takes about 2 years. So again, that's a long process that is going to be marked by periods of heavier use and probably what we would call abstinence, non-use. Over time, the use will become more stable and harms and problems will start to emerge. And that's usually at least 2 years later after the incidence of first use. Some point within that window of like having the problems be experienced, a portion of people will seek out treatment. About 15% will seek professional help. So the majority of people who go through this trajectory of incident of use, regular use, harms from use, they never present to treatment. We never see them. So we're seeing a very specific subset of the population, and so we're colored by that, I guess. Potentially, it's the ones that we see that are the more severe end of the spectrum. The average time from the first episode of recovery to like full long-term sustained abstinence or remission or whatever words are being used is going to be about 4 treatment episodes that take 7 to 9 years. And this is generalized across a lot of different substances and such, but that's kind of the average that we have. So the standard is return to use, and the standard is this takes almost as long to get it from incident to problems to get fully out of it. And then we find that about 60 to 70% of people who enter who do end up seeking treatment will sustain full remission within 3 years of having initially met that significant full diagnostic criteria. So there's going to be a 30% of persons who are in that kind of higher need group, more frequent remission, return to use. Some of that 30% is also people who will pass away as the result of their use disorder or other comorbid health conditions and such. Okay, next slide. Next slide. Joyce, can I do it or do you have to do it? Okay. So we have this sort of this trajectory of from incident of first use into treatment and recovery is kind of sets some of the stage. And then also setting the stage, as you've all seen this, I think we've put this in all of our talks. We talked about this a lot. We talked about motivational interviewing in the fall. This idea of stages of change. So why is it that there is why do people not just like decide to change and then stick with it? So we find that research literature strongly supports, everyone's clinical experience will strongly support, is that many of the people we work with are going to have fluctuations in how ready they are to change certain specific behaviors. And that changes in motivation and based on internal, external factors is going to interact with how much motivation, how much energy, commitment an individual will have in sustaining treatment goals at any given time. All right, next slide. This is the continuum of use. So once someone has entered into that regular use pattern, then we will see this kind of continuum happen. Even when a person is in treatment seeking, we expect them to be moving back and forth along this continuum. So many people who enter treatment will never get back to the severity of their initial prior to treatment seeking pattern of use. There will always be some amount of moderation that will have happened. Um, just as there will be some people who do one treatment episode and then they maintain lasting abstinence. There's going to be a good subset of people that end up looking kind of like moderate users as they fluctuate between no use and some lower, moderate, safer use that causes less harm for them. But this is going to be very individual differences where people kind of land along this at various points in treatment and various points in their recovery. Next slide. Okay. So knowing this, knowing that the substance use disorders are addictive disorders, are going to be conditions where a person's through the course of use, development of disease and treatment recovery, they will fluctuate in how much harms they're experiencing, how engaged with treatment they are, how much actual drug they're doing, and are they going to have no drug use showing on their talk screen or something like that. We know this is going to be just part of the treatment and recovery from these conditions. So we as providers need to own that and take responsibility for starting to address the return to use before it happens. I argue, I think many in this group will argue, is that that's like the first time you see someone is when you already start planning for return to use. So having kind of really open, transparent conversations from the get-go, where you're framing expectations around it's possible you will never use again, having made this decision coming in for treatment. It's also possible that you'll experience a setback. For many people, when they experience setbacks, they can have this kind of flash in their head that happens. What we call in psychology, we call it abstinence violation effect. So this idea where because I've not done it perfectly, I should just throw it out. Start like I'm a failure. I can never do this again. I describe, we talk our first session, the clinic that I run, we talk about, the example, the metaphor of like a New Year's resolution. So if someone their New Year's resolution we'll stick with the diabetes example, to eat less sugar, to be better in line with their health. So if a person that's their New Year's resolution, I think New Year's resolutions last on average like 2 weeks or something like that. So you set the New Year's resolution as like, I'm not going to eat any sugar, any processed sugar this year. And the person, goes 2 full weeks and then they arrive at their best friend's birthday party and they get offered a piece of cake and they eat the cake because it's an amazing cake and it's an amazing birthday party and everyone's having so much fun. So if the person then encounters abstinence violation effect, what happens is they kind of wake up and they're like, oh my gosh, I wasn't perfect. I ate cake. I'm so terrible. I can't do this New Year's resolution. I'm just going to throw it out the window. I'm going to go back to eating just as much sugar as I was before when I was concerned. What we want people to do and what we can help educate them about from the first point of contact is, can you treat that piece of cake as a setback, something you can learn from, something you can use data for, maybe to modify your goal, maybe to modify your thinking. So if it's instead you wake up in that morning and you're like, oh wow, okay, I ate a giant piece of cake at my best friend's birthday party. It was really fun. That was important to me to have fun there. And also, I know to help my blood sugar, I should do a bit more exercise today, and then I will feel better. You can apply your coping skills, you get back going, and you reaffirm your goal. You just now have a plan that maybe I will eat cake at my friend's birthday party, and I will have a plan to do more exercise the next day so that I can better stabilize my blood sugar. We can do that with addiction. The big thing is like, come back to me. Like if you think everything is perfect, and I only want to talk to you if everything is perfect, that can mean that people don't return. I want to like normalizing this happens. I won't think you're a failure. I'm going to encourage you not to think of yourself as a failure, and we can use it. We will get data from it. We will like rally the troops, get all the coping skills on board, and this will be something that we can all do together. So I think that is, if that is one of the the take-home messages from this is that it's never too early to plan for return to use. It can actually help mitigate some of the most self-defeating cognitions that can get present in this really challenging change process that has to occur. Next slide. Okay, so then there's kind of this, okay, so it's normal, it happens. Why does it happen? The client may ask you this, the patient may ask you this, you may be asking this yourself. There's lots of reasons. There's no one reason. A list of some of the reasons is that they were not far enough along into a maintenance stage of their like addiction process. So they needed more time. They haven't been able to fully move through all of the stages. They maybe were not prepared enough. They weren't ready. That's okay. Now they could be ready. We also recognize that it's just hard, and that the contingencies and the motivation can change. So what seemed achievable and possible when the person was in a good, stable relationship and everything was going well and they were gainfully employed has now seemed impossible that their partner has broken up with them, and their boss gave them 2 weeks notice that they're about to be laid off. So they need different skills to be able to get through that time and maintain recovery. So that's kind of also with life happens, like things we can't always plan for, the clients can't always plan for, just happen and kind of take people by surprise. And it's also possible that the coping skills that they had been engaging with just don't work the same way that they did, or they need additional new coping skills to be able to kind of deal with and confront the world. The partner has been walking on eggshells, being as nice as possible. They're so excited about this abstinence that's happening, and it's been a great couple weeks. And now I'm going to bring up every fight we've ever had, because you've been good for a while, and I think you're ready for us to have all these fights. So now we need to move from having kind of like the avoidant communication style where we like have a false peace to having like interpersonal effective communication, to be able to maintain recovery. And those require different sets of skills. So it can be as simple as, I guess not simple as a bad word. Fix your relationship is not simple, but it can be as direct of a process as something like that. Next slide. Okay. Another thing that can happen is this idea of recovery drift. And this is different people use different words for this, but there's kind of this is a little bit with a New Year's resolution thing as well, as like this is just natural human behavior. When things are new and exciting and novel, we can put all of our time into them. We really prioritize and centralize them in our lives. And then as they get more part of our like new normal, we don't centralize them as much. They take up less time, we put them less priority, and then we get further and further away from our goals. I think one example I think of like clients that are going, maybe doing like a 12-step model for treatment recovery, and they're saying, go to 90 meetings in 90 days. And that is, they build their entire schedule. They say no to everything else in their life except going to those meetings. And then after the 90 days is up, it's natural that you are going to step down and go to fewer. But what then happens is, you are not going to one every day. So you're like, I'm going to go every other day. And then you're sick on Tuesday. And then, your kids, your car breaks down on Thursday. And now you've not gone for almost a week. And the skills and the reminders that you were finding really helpful, you've now become distant from. So it can happen with the most meaningful, most intentional clients who are really, really trying to do all of the things that are helpful for the recovery. Life happens. It's harder to keep things central when they're less new and shiny, and the harms are not as apparent and in your face, I guess, as well. Okay, next one. Okay, so what do we do kind of in the like room sort of when people come in and are like, hey, I had a return to use, return to engagement. I like help me provider. And the big thing is just to listen, like keep like know your own emotions about this. You're probably disappointed along with the client. You may be disappointed specifically because you've been working so hard with this person. You've seen how bad this will be. You know how there's going to be some really significant adverse consequences. You may be sad, but just reminding yourself that this happens. We know it's part of this process, and we're really glad that they are here talking to us, and that's different. I think as Joyce spoke to is right. Like it's different from last time because the last time you were by yourself and you weren't in treatment, and now you are, and you're coming to talk to me, and you've already done things so much differently than you did before. So I'm so much more hopeful than I would be. And then we have a few other steps. So the first one is going to be assessment. So I think those are my next slides. I think is how we did this. What's my next slide? Yes, this. Okay, so assessment. Our big thing that we think of sometimes with assessment is going to be, is there a comorbidity that's going on that we haven't been addressing in a way that is as I guess as strongly as maybe we need to. Can be common with persons with substance use histories, especially if they're starting to use substances. Some of those first age of onset ages are young, 12, 14, 15. So some of the comorbid symptoms of a mental health condition would have developed right alongside their substance use. So it's hard if we do those like timeline. I think Caleb had the timeline interview last time, where she had like the onset of different symptoms and the onset of different uses. We know some kind of critical windows for onset of different mental health conditions, but if you've been using alcohol, you've been using cannabis, you've been using opioids throughout all those critical windows, it's hard to know what are the symptoms of the use and what are the symptoms of a comorbid mental health condition. Remove the substances, and then those things stick around. And then it's like, oh, okay, it's not just the use. It's actually this additional comorbid mental health condition that we need to deal with. Can also be that even in people who don't have comorbid symptoms or comorbid mental health conditions, since the substance has been so central to their coping, and they can maybe have avoided some of the stressors and triggers. The environment has supported their not being overly stressed or triggered during early recovery. But then weeks, months, years kind of stack up, and it's like, okay, I just don't have other good coping skills. So it may not be to a full level of mental health, comorbid mental health condition, but it may be a deficit of coping skills that we can supplement with psychotherapy. But so it's going to be highly common, though, that the person you have in front of you with a substance use disorder has a comorbid mental health condition. So that's where assessment can come in, and assessment will work better now that they've had this period and this window of abstinence. Next slide. Okay, most common lifetime prevalence comorbidities will be depression. This is for opioid use disorder specifically, but these rates look pretty similar across other drugs as well. But yeah, depression, dysthymia is the old term for like a low level kind of persistent depression, bipolar, panic disorder, social phobia, generalized anxiety disorder, some comorbid personality type disorder, and then post-traumatic stress disorder. We see also within specifically the stimulant use disorder population, we see very high rates of comorbid ADHD. So any of these things are candidates on the table to be assessed that can be followed up with adjunctive treatment. Okay, next one. Okay. Can do a range of like general behavioral interventions that can help with return to use. So it can sometimes just be that motivational conversation, understanding kind of what happened in this specific incident, learn from it, make a better plan for next time. Can be the addition of different skills. So it may be a skills deficit, need for more coping skills, that type of thing. And then it can just be about that kind of like that lifestyle balance. So that shift I was talking to of like the absolute focus on recovery related activities. Now we're maybe too much like all in the real life, and we need to come up with a better balance of how we integrate things so that recovery, like how much of the life day is focused on recovery-related activities specifically, just need to be recalibrated. Okay, and next one. And then this is a specific skill that, or specific technique that can be applied within the context of that kind of initial session after someone comes back after a period of having returned to use. This is a behavior chain. It's from dialectical behavior therapy. If you Google it, these a bunch of different worksheets that will come up for you. And this is where you do like almost like think of like the forensic autopsy sort of like you go in as a scientist, you're very objective. We notice emotions, but we try not to like overly feel them in the moment. And we just go through and we're like, okay, what happened? What was going on? I always think of there's an acronym that they use in 12 step. It's HALT, hungry, angry, lonely, tired, I think is the 4 triggers. It's usually something like that, are things that people will put in these prompting events or vulnerability bubbles. Um, but being able to really dismantle and understand like what were all the things that were going on that you think made it so that you were at higher risk for the return to use episode. And can we pull out each of these little bubbles and look at them and figure out like, do we need more coping skills for this? Do you need specific psychotherapy for this? Like, is it that you are, you realize like, oh, it's because I've been isolating in my house because I have depression. And my depression symptoms flare when it gets, cold in the winter. And ice can, like, we have that all mapped up and we can see it all. And then it's like, oh, hey, we have medications we can help with for that. We have behavioral interventions we can help with for that. We can have psychotherapy interventions we can help with for that. Like, none of these things you have to just like grit through for the rest of your life and hope it doesn't happen again. We can dismantle, isolate, and specifically target any of these bubbles that come up as areas of concerns. So it can be a really good opportunity to help the client partner with you, get talking about what happened, remove some of the stigma and the shame around what this event. And we go in as scientists, we're exploring, we're gonna solve this. I have confidence that we can, borrow my hope, and from there we can make a different plan for next time. So you don't have to just worry that this is always looming. You're going to approach it differently moving forward. I think that is yep. Now it's medicine. Go. Thanks.
Thank you, Meredith. So now some medical interventions. One of like when this whole echo started, however many years ago we started, it was super duper focused on opioid use disorder. And we tend to think of MAT or MOUD or whatever letters we want to call it today or tomorrow, pertaining to opioid use disorder. But truthfully, just about any condition that we're talking about does have medication that can assist in the treatment of the condition. So adjusting our medications, as Meredith has already touched on, rescreening or screening for the first time if we haven't already for any co-occurring disorders, anything else that might be going on, and then the potential of a higher level of care depending on what you're able to offer within your doors. Is there another place? Is there another location? Is there another type of intervention that this individual may benefit from? So just kind of along with that, the individual doing the deconstructing of what led to the return to use. Also our job to look from our side of it too. Are there other things that need to be addressed in a different way? So you get to kind of be an investigator, not just for what your client has experienced, but how you guys are addressing what they've presented with previously and what they're coming to you with now. So some medical interventions, honestly, I am so incredibly lucky to work in an office where we provide integrated care. So it is truly my daily experience that it gets to be an interplay between medical and behavioral health. The things that I discover from my patient, the things that the behavioral health team discovers from our patient, and recognizing how they overlap and feed and support one another, can make a really huge difference in our experience of what we're able to do with the patient. Some of the information I'm able to gather from other people who've been in the room before me. I get to come in with already good sense of maybe what direction we need to go in, but it gives me an opportunity to maybe ask questions a little bit differently than if I'd been going in cold on my own. it is, in my mind, the best and therefore only way to do any work with patients is on an integrated medical and behavioral health team. But if you do not have that benefit, always be thinking not just what is the diagnosis, what are the medications I'm going to use, but what are other ways that this individual can be supported, and questions that you may ask to help pull that out. The deconstruction of the return to use episode, or the autopsy of a relapse. We don't use the relapse word anymore, or try not to, but it really is kind of going back, like what happened, what led up to this. In the discussion with your client, you may see some things that are happening, maybe some patterns that they haven't been able to see themselves yet, that you're able to reflect back to them and see if they are seeing it too. When you're doing that slow pulling apart, it's also an opportunity to ask questions about what is another way you could handle this? What is another way you would like to respond to it? If you had to do it over again, what would you do differently? So you can see that all is a very mixed picture of behavioral health interventions and questioning, along with this response, with the example of depression, there are medications that we can use for that. Oh, this happens every year at this time. Do we want to think about light box therapy? Different ways of helping addressing, like, when this comes around again, how are we going to have a different experience? The other thing is, do we have the right diagnosis? Maybe someone has had a very long history of using methamphetamine, some stimulant, and they've been given a diagnosis of bipolar. And it's, well, really, was it bipolar? Or is it like, was that diagnosis always given when you were in rehab, and you had only stopped using meth 3 days when they gave you that diagnosis? I have a patient very much fit in that category. She started using methamphetamine in her teens, received diagnosis of bipolar in her teens, had been on a ton of different medications for bipolar. Nothing had worked. Everything made things worse. And then so we started peeling apart, taking things away, really streamlining. She was not using methamphetamine. She was not using opioids. She was not using any substances at all, occasional marijuana. And then she really began describing a pattern of behaviors and emotions that really actually did fit with bipolar. So we started simple and added in certain medications one at a time, very slowly. And she now is incredibly well controlled. Mood is stable. She has bipolar 1. She also has ADHD, and we started her on medication for that. And getting at what is going on. And sometimes it is a process of patience, where you don't get impatient with yourself in the process and give up on it and throw in the towel, because that can happen too. You're like, I've made all these medication choices and nothing's working. And I feel like I'm not helping you. But being patient and persistent, having a good open dialogue with your patient, getting them to give you feedback on what they've experienced, what helped, what didn't help, engaging with counseling, and adding in that other crucial diagnosis. We didn't have that ADHD diagnosis early on, but we came to it, got her on appropriate treatment. So right diagnosis actually did turn out to be bipolar, but we didn't have an additional important diagnosis of ADHD, made it. And then we did get the right interventions in place, and she's doing amazingly well. Actually, we're in a place with her recovery right now. She has completely weaned off her buprenorphine. It's early, but she's been on it for about 5 years, and she is now fully weaned off of buprenorphine and not having opioid cravings, and is feeling really strong about her progress and the place she has gotten in her recovery. Does that mean that someday she might not need to be back on meds? She doesn't want to hear that from me right now, which is totally fine. She's basking in the glory of her achievement, and she absolutely should. But that's also why we're still here and not like, okay, you're off of meds, bye. We're still here to support her in that transition from some of the medications she's been using to support her conditions to not needing them. What does it look like now that we've moved away some of that scaffolding? How well did she build her house? Honestly, I think she built a damn fine house. She's done a great job. And then, are we under treating? Kind of similar with this patient. Are we under treating? So when we first started with the ADHD, and I was like, I'll just give you a little methylphenidate, okay, just a little bit. She's like, that did nothing. I'm like, let's give it some more time. She's like, I don't have time. So, was I giving her the right dose? Like we started with the dose, could I have escalated a little more quickly? Probably. But tiptoeing into this, she was one of my first ADHD patients that I did venture into, like with history of stimulant use disorder and bring this. So, we were treading lightly, but we both learned from each other, which is another wonderful thing. We learn so much about our patients. We also learn a ton from them. And then the primary condition, what is the main reason these individuals are coming to see us? We're in the world of treating addictions and substance use disorders. So, the primary condition, do I have you on the right regimen, the appropriate dosing for, let's say, your opioid use disorder, for instance. So under treating, actually, when I moved, I'm from here, I'm from the region, I'm from Northeast Tennessee, and ended up my first 10 years out of residency practicing in New Mexico, very rural area. Pretty much like if you had a license, you just do some stuff and take care of some people. Nobody was really asking questions because it can definitely be a healthcare desert out there, a literal desert and a desert in so many other ways too. So when I moved to Tennessee and started doing this work, a lot like we had much stricter limits on the amount of buprenorphine we could prescribe. The kind of feeling of oversight and being watched, I was convinced for the first 6 months I was going to end up in doctor jail just simply because I was practicing the way that I had been practicing in New Mexico. And I was like, oh my God, was I doing it wrong there too? No, we just have different state legislature, which was bizarre to me even. Anyway, it was quite a cultural shift in my head when I came here. And then reading some of the literature, under treating is definitely something that it wasn't just a here thing. It happens. The idea of like how many receptors are in the brain that are going to need to be fed by your partial mu agonist opioid, buprenorphine, and nobody really needs more than 16 and all this stuff. I'm like, well, FDA tells me 32 is the maximum dose. So why am I cutting it halfway off in the middle? And then you throw in some fentanyl, and how does that affect how I'm dosing people? So sometimes some people struggle with trusting someone who has history of a substance use disorder saying, I need more medication. Our own patients feel bad saying, hey, I have a substance use disorder and I need more drugs from you. It feels very uncomfortable. They're not going to tell you that. So if you're taking a medicine for whatever the condition is, and it is not having the desired effect, why do I have you on the medication? I need to adjust the medication. I either need to max it, I need to change it, I need to do something, right? But I also need to make it so that you feel comfortable to let me know if it's working or not working so I can adjust it appropriately. Do I need to pitch it in the garbage pail? Do I need to adjust the dose? Do I need to bring in an augmenting agent? What do I need to do as my job as a physician managing medications to make your life situation more tenable? So when it comes to, and it's a simple one, buprenorphine and managing that dose, I get to tell you guys one of my favorite analogies. And it's mine. I came up with it all myself. I get to take credit for it. You may not think it's as great as I do, but I love this one. So your buprenorphine dose is a number. Your buprenorphine dose is like a pair of pants. It's not a plate of cookies. So someone who has a substance use disorder and that feeling of like, if you're going to tell me I can have more, I'm going to take more. I'm going to take that plate of cookies. I'm going to eat the whole plate of cookies. And I totally get the plate of cookies thing. Like you got a plate of chocolate chip cookies or even oatmeal cookies in front of me. And I'm like, I don't want these, but they're right there. And if I just eat all of them, they're going to be gone. And they're going to be more for later to tempt me because I'm just going to eat them all now. Right. And so that feeling of like, I really don't have control over this plate of cookies. So you said I could eat whatever I wanted. You told me I can have whatever dose of buprenorphine I want. So like 8 milligrams, 12 milligrams, 24, like when are you going to tell me no? I feel bad asking for an increase in dose. I feel like I'm doing that addictive thing, that addictive personality that I have is just going to say, get more cookies if you can get more cookies. Give me more buprenorphine if I can have more buprenorphine. Like your buprenorphine dose is not a plate of cookies. It's a pair of pants. So you've gone to the mall and you need a new pair of jeans. and you try on a size 2 and they are not fastening. Or maybe you put on a size 4 and you can't actually get the button to button, but you can't sit down because if you do, it's going to fly open. If you sit down, your rear is going to come busting out. You can't even sit down. They are uncomfortable and you are angry. It is the wrong fit. Well, then you put on a size 16 and like you don't have a belt. You have to hold them up in your hand. You can't run like the house is on fire. You can't run out because your pants are going to fall down if you run. You're going to fall flat on your face. It's the wrong size. What's the right size pants? What's the right dose of buprenorphine for you? So helping patients see that it's not a matter of the number means something other than your right fit. And with any medication, we're adjusting it. I want it to be the right fit. So if I need to go up or I need to go down, your feedback to me is incredibly important. Here in the state of Tennessee, especially, the feedback we get from guidelines, legislation, is we are limited on the number we can give our patients. So all of a sudden, the number takes on a significance beyond just getting somebody on the appropriate sized dose. So I think first thing is we need to treat the person in front of us. And I recognize we concern ourselves with diversion. It's important. We can't do that. That's illegal. That is illegal. Does it happen? Yes. Are we detectives? No. Our job is to make certain patients are doing with their medication what they tell us they're doing. And we do that by things like toxicology screening. They're keeping appointments. They're engaging in care. They're making progress towards their goals. It might be slow. It might not be a pace that we think is the right pace, but they're making progress because right pace, what is that to us? It's very different to our patients, what the pace is. They may be impatient with their pace, but they are making progress. Those are the things that matter more than what's the actual number of milligrams or micrograms that our patients are taking. So under treating, we got to get the right size on our people. I love that analogy. So with medications that we're using, because that might be a place we decide like they've had a return to use, maybe we don't have the medication dosed at the right place. You know, someone who's got the buprenorphine dose of 8 milligrams and they've had some cravings or they're not really having cravings, but they've been having using dreams and they're particularly stressful. Do we need to adjust their dose? Some medications, I'm going to pick on sertraline because it is my least favorite SSRI. When you start them at 50 milligrams, nothing happens. You raise it up to 100, nothing's happening. Be like, okay, let's get to max and see if we get anything happening and moving with this medication. So I start it, nothing's happening. It's actually good feedback to me. You did not have side effects. So I know I can go up on it and probably still tolerate it. So we did learn information even with a starting dose that maybe I've got some room to move and get some effect. If you're having side effects, how bad are they? Can we just wait it out? Is it tolerable? Because most of the time with side effects, you wait and they take care of themselves. But if they're untenable, you can't stand it for another minute, it's got to go. You have angioedema, it's got to go. So depending on the severity, what we're going to do if someone's experiencing side effects. Tolerated and maxed out, like that sertraline, they tolerated. I got them to 200 and they're like, feels no different than the 50. Then I need to change the medication. That question again of do we have the right diagnosis? The patient that I mentioned before with bipolar 1, like, let's just look at this as anxiety and depression and treat it as such. We went through so many different medications. We did not have the right diagnosis. It was bipolar 1. And then if you do have the right diagnosis, but we're still not getting the desired effect, again, that example of she had ADHD as well. I wasn't treating that. I hadn't diagnosed it. And I certainly wasn't treating it without a diagnosis of it. But once we did make that diagnosis, yes, I am running the heater in my office and now it's too hot. But once we did identify that diagnosis and treated appropriately, all of a sudden she was zooming. She was making tons of progress. She back to work, more engaged with her children, better sleeping habits. So those are all different ways in which maybe a medical intervention is going to make a difference with what our patients are experiencing in their ability for getting back on that horse and riding down the road of recovery until we possibly have another return to use episode or a return to use scare where it was close, but it didn't happen. All wonderful opportunities to engage and learn and grow with our patients. But then again, maybe it's not even medications, maybe it's something else that's going on in their lives. And so that multidisciplinary team looking at things like food scarcity. Do you have enough food in the home? Are you worried about feeding your children? Do you have enough food for them? Are you feeding them, but you're not eating? And so, as Meredith was mentioning, hunger. Like, I was hungry. I've definitely had patients tell me that their use of methamphetamine was so they wouldn't feel hungry. They don't have shelter. That was another one. It's February, it's raining, snowing, I'm cold, I'm in a tent, I use meth, I don't care. So housing, the need for housing, that's a big one. Work, purpose. Are you working? Are you working at a job where you feel like it's demeaning, that you have people who talk down to you and treat you like an idiot, because it's the only thing you could get because you weren't able to finish and get a GED. Finished high school, but you really wanted to go to college. You have a few classes, you could do more, but things got in the way. You have issues with parenting. You're having a really hard time with one of your kids at home. This is your first time parenting sober, and your kids are looking at you like, who the hell are you? And when did you show up? They've been used to parenting themselves. And so having to like learn how to be a parent to kids who are like, I don't remember you in my life before. Even though you've been here the whole time, you haven't played the role of my parent, and now you're trying to. So helping them navigate how to reparent their children, transportation, access to a valid driver's license, domestic violence, financial abuse. They're with someone who is holding the purse strings, and they can't do things that would help and benefit themselves because the individual is basically like, I've got control of you because I've got control of the money, and I'm not going to cede any of that power to you. So what other things might your client be facing beyond mental health diagnoses, medical medications needing to be adjusted? It could be all of the above. Um, Working to enhance our clients' recovery capital. So looking at different ways of navigating what they're experiencing, including, adjusting meds, making the right diagnosis, getting the right intervention, engaging them more with behavioral health, increasing behavioral health, I'm saying the same words over and over again, because I'm looking at the clock and I'm trying to talk too fast. But basically trigger identification. So that deconstructing of the return to use episode, what was going on? How do we identify that trigger sooner rather than later, that it's happening and that it might lead this way again? One of my favorite strategies that our behavioral health team uses here is urge surfing. You feel it. It's a wave. It's gonna peak, and just reassurance, like it will go away. It will recede. And using different ways to help you urge surf, distraction, denial, doing something, delaying anything. Like, I really, really feel like I'm going to give myself 30 minutes and I give myself permission to do it. Like, I'm going to go, do whatever it is that I really feel like I want to do right now, but in 30 minutes, hour and a half later, is there something I was going to go do? Oh, yeah, I don't need to do that anymore. And then use refusal, because if it's that certain friend that comes around and there's no avoiding that person, how am I going to say no? Practicing saying no. I had one of my clients who would actually practice in the mirror telling that one guy, no, I don't want it. No, I'm not using anymore. No, like literally practicing saying no and imagining this guy that he needed to say no to. Engaging them in mutual help groups, being part of a peer group, that in and of itself is therapeutic. It's reinforcing, it's encouraging. Seeing people who are not as far along as you really helps bolster morale. And then seeing somebody who's gone even further than you can help you see that it is possible. So just being in a group of peers alone is therapeutic. Teaching people that there are things that they can do that's fun, that don't require substances to have fun. Reminding them fun is something that is doable without substances. Resource referral, just that slide before this one, that's what that was all about. Another level, these next 3 slides are an entire course, like weeks worth. It's a big fat book. There's a lot when we think about what is the right place for your client to be. So if I've got someone who's stable in their opioid use disorder, but they are smoking or shooting up meth every day, all day, this is a big issue. We are not okay. We are not in a recovery place when it comes to that particular substance. So maybe they would benefit from a higher level of care. Maybe they need to go to an inpatient setting. And so this is, the different access points to different levels of care, what they are, and all these lovely numbers with decimals and what that means. Basically, there is a way to go through and assess what someone's appropriate level of care is. And there's an entire, like, you can go print this off and use it with your patients and see if you've got them in the appropriate level of care. And it's based off of the different ASAM dimensions to help sort of assess, like, where are you in your recovery landscape and what type of intervention would best suit you, best fit you for engaging recovery in a meaningful way. And I will be honest with you, I might have somebody that they are needing, they would qualify for, they are stability point matches residential inpatient services, and they look me dead in the face. There's no way in hell I'm going in. I spent 15 years in prison. I'm not going into any institution ever again. I'm not even going to the hospital. If I die, I die. I'm not going someplace where somebody else controls the door. Okay, so I have all this lovely stuff, and it's not what my patient's going to do. And that is okay. And that's part of meeting your patient where your patient is, their willingness, their ability. I am the only one who takes care of my aging mother. If I go inpatient, she dies. I can't have that. Nobody else is going to take care of her. Are we going to make this person go inpatient? No, we're not. Are we going to withdraw our care because they aren't going to go along with the treatment plan we came up with? No, because it's not going to, it's actually going to make it worse. They're probably going to want to go and use more because we're telling them you have to do that. Like, it's a balance. What are they able to do? What is reasonable? What is a treatment plan that meets them where they are and matches what their abilities are? Period. So this information is useful. It can really help direct where a patient needs to go. But at the end of the day, it is what they are able, not just willing, but willing and able to do. And someone may really, really, really want to go to inpatient services and everything is lined up perfect for it. And nobody has any grant money and they don't have insurance. So guess where they don't get to go? Inpatient. So there are a lot of reasons why level of care and what our patients are able to do are not going to match. But when you have a situation where you're trying to figure out, like, what's going on, do we need to do something different? We've tried all these things, we've done this, we've done that. A higher level of care would be more appropriate. And sometimes it works out and we do get them into the higher level of care. But just because we can't get them there doesn't mean we should stop trying what we're doing on the outpatient level either. This is a cute slide. It's 1:14. We're done.
All right, thank you for that excellent presentation, both of you. Before we wrap up here, I did want to mention, for those of you who have been checking the chat, Dr. Delavecchia did volunteer his contact info there, because there may be a fair number of us that are going to the ASAM conference in Denver. So as he said in there, I do think it's a wonderful time to meet up. They're having an informal 10SAM meeting because many of us see each other in virtually on this, but we do not ever see each other in real life. So it's always nice to have that touch. So feel free to shoot him a text if you're going to the conference already and you're interested in meeting up. Aside from that, I will go ahead and close things out here because we have hit our time limit. We will see everybody back in 2 more weeks, and we'll have some exciting case presentations related to this topic. Thank you everyone for being here.